Thank you, David, very much for putting the question and framing it well. And thank you, Representative Mazza, for chairing this meeting and allowing us all to come together here. My name is Sandy Eaton. I'm a staff nurse at Quincy Medical Center in Quincy, Massachusetts. I've been in healthcare at the bedside for 45 years, most of that time as a registered nurse. And I'm on the board of directors of the Massachusetts Nurses Association, and I represent M&A on the steering committee of MassCare, the Massachusetts Campaign for Single-Payer Healthcare, and at the newly formed National Steering Committee of the Labor Campaign for Single-Payer Healthcare. I feel like I'm here today not only representing the nursing community, but the voices of a number of individual, unorganized people across the Commonwealth who feel victimized by the defects of Chapter 58. And I'm also here, in a sense, the CEO of one of our vital community health centers, Bill Walczak, at the Codman Square Community Health Center in Dorchester, which is a 250,000 resident, very diverse working class community in the city of Boston. Wasn't able to be here, but shared many of his angsts with me, his concerns and his issues. Organized nursing in Massachusetts has long held the belief that health care must be a right, not a commodity. We witnessed the harm done to the Commonwealth's most vulnerable during the privatization juggernaut that peaked in the early 90s, and we knew that the deregulation of hospital finance in 1991 would lead to as much devastation in the private sector as privatization had to the public. Since we realized that serious healthcare reform efforts need to move forward on three fronts simultaneously: access, affordability, and quality, we entrenched ourselves in the movement to build a single-payer system in Massachusetts and nationally, even as we launched the statewide campaign for safe care to reverse the damage done by job re-engineering consultants in diluting and deflecting the essential advocacy role of frontline nurses. We contributed as much as we could afford to the omnibus ballot initiative known as Question 5 on the Massachusetts state ballot in 2000, which, if adopted, would have required a system of universal health care by July 1st, 2002. $5 million in around-the-clock attack ads, mostly paid for by our not-for-profit health insurance companies, doomed this initiative despite high polling numbers early in the campaign. We worked to help amend the Massachusetts Constitution to make access to comprehensive, affordable health insurance the right of all residents. In light of frightening statistics showing the high numbers of deaths and injuries suffered by patients in the current healthcare marketplace, we helped build tremendous grassroots pressure for the passage of a legislated enforceable limit to the number of acutely ill patients an RN may be required to care for at once in Massachusetts, only to hit a glass ceiling, which we pledged to shatter in the current session. The $100 million deficit in the FY08 budget to pay for Chapter 58 was the occasion for defeat of this vital patient protection measure. On July 14th of this past year, published accounts revealed that the CEO of the Massachusetts Hospital Association pledged $28 million to help reduce the state's deficit trying to pay for Chapter 58, but only if safe RN to patient ratio legislation was defeated. By July 17th, 3 days later, the bill was dead. I'd like to mention how much time do I have?
As long as you like, sir.
I'll try to be to the point. I mentioned earlier that there's unorganized, spontaneous movement across the state of folks that are very frustrated. Some folks went out, mostly in Berkshire County in western Massachusetts, and collected signatures on a petition to Congress asking for this hearing. And about 650 signatures were gathered in front of supermarkets and other places in a short period of time. And they want their voices heard. Let me just run quickly through several cases. We've heard some very moving cases so far. I'll try to be brief, but I think they really point out the gaps in the thinking and the rationale and the implementation of health reform in Massachusetts so far. A class of University of Massachusetts of Boston's nursing school recently visited the Cogman Square Community Health Center, and I owe this story to Bill Walczyk, as I said, from Cogman Square. And it's in the first person. One of the students happened to have with her a previous assignment, which was to find out what kind of insurance was available for an uninsured person in the new healthcare system. She used information for a 58-year-old single female from Fall River working as a nurse's aide and making $32,000 a year, which is above the annual income that would qualify her for subsidized insurance. The options were eye-opening. The cheapest plan is from the neighborhood health plan. The premium is $4,424.64 per year, or $368.72 a month. But you have to add the additional expense to get a true picture. Co-payments for office visits are $25 per visit and $100 for an emergency room visit. If you need hospital care, you pay the first $2,000 out of pocket. Then 20% co-insurance after the deductible is met, and lab charges are subject to the deductible, meaning you have to pay full charge for lab services until the deductible is met. And Bill, in his blog on the WBUR website in Boston, entitled this episode, 58 years old, $15 an hour, no insurance, what next? I have a brief story from the Center for Women's Health and Human Rights at Suffolk University in Boston. It was a study published in the spring of 2008 entitled Women in Health Care Reform in Massachusetts. Here's a case that they discussed there. Kay is a type 1 diabetic working full-time as a pharmacy technician. A former free care recipient, she now is covered by Commonwealth Care. Based on a weekly net income of $339, she is eligible for the Tier 3 subsidy. Her current premium is $70 a month. Her out-of-pocket medical expenses for her diabetes medications are $10 for generic and $20 for name brand until her annual cap of $500 is reached for prescription drug copays. Until she reaches that cap, she picks and chooses which medications to purchase, sometimes skipping 1 or 2 prescriptions if her income is insufficient. Given her low income, Kay would like to work overtime whenever possible. However, she needs to be careful not to earn enough to push her Commonwealth Care to Tier 4, which would result in higher copays than she can afford. Kay worries that if her income increases by even a relatively small sum, she will lose her Commonwealth Care eligibility and will be required to find much more expensive alternatives. My friend Bill at the Community Health Center is faced with extinction. The contradictions between a lack of revenue coming in and the expenses to meet the mission of the Community Health Center, which is to give care to anybody that shows up and needs it, regardless of costs, is really driving the community health centers in Massachusetts, many of them, most of them, in a very difficult direction. The Community Health Center has taken a number of financial hits this year, Bill relates. We started off the fiscal year in October with about $200,000 in cuts from a safety net program that was eliminated from the budget. We took another hit when the governor's 9C cuts, emergency cuts in the budget that the governor is allowed to take when fiscal crisis is imminent.